Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the left of your webinar. You may also download a copy of today's presentation using the Resources pod located below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator, Drew Solo. Sir, you may begin.
Welcome everyone to today's webinar. This is Drew Solo with the American Hospital Association. I'm pleased to be moderating today's event, Outsourced Service Provider Costs, how to ensure these costs are managed and monitored. This webinar is brought to you through the generous support of VI Healthcare. Hospitals rely on outsourced services to operate and meet the needs of servicing patients. These outsourced service agreements are complex and have both financial and operational implications. These agreements require a disciplined approach to managing and monitoring costs so they don't escalate rapidly and exceed competitive market pricing. In today's event, you will learn how to create a disciplined approach based on data and frontline user experience to achieve the optimal financial and operational outcomes for your hospital. The speakers will share case studies of hospitals that have closely assessed, monitored, and managed their large outsourced agreements and the positive results they achieved. Let me briefly introduce today's speakers. Lisa Miller is a healthcare margin improvement expert and also the founder and CEO of VI Healthcare. Richard Dormer is also a healthcare margin improvement expert, and he's the Chief Operating Officer at VI Healthcare. Having said that, it is now my pleasure to turn the floor over to Lisa Miller, who will begin our presentation.
Great. Thank you, Drew. Welcome, everyone. I appreciate your time today on the webinar. I promise it's going to be packed with lots of content, case examples, and great information. And like Drew had said, if you have any questions, there were a few people who submitted questions with their registration. If you have any questions, please do submit them. We'll have time at the end of the presentation, so welcome. Just going to give you a very brief overview about why VI Healthcare, why Rich and I are giving this presentation today, and just it's our experience from the last 20 years of working with hospitals in their non-labor cost reduction initiatives, where we price benchmark, perform data analytics, utilization, and contract reviews, and it's a comprehensive review of whether it's supply or we do quite a bit and have done this work for over 20 years in this outsourced service agreements spend category. So we've got, as you'll see, lots of case examples, lots of best practices from hospitals throughout the country, and we're going to share that with you today. So as Drew did provide an intro, I won't go through this slide again, but all to say that we're going to be talking about these outsourced service provider costs and how to ensure they're managed and monitored. And these costs are some of your really large outsourced provider costs. They could be dietary, they could be lab courier pickup services to dialysis. I mean, it really depends on the hospital's needs and requirements, but these are your larger outsourced agreements where there's quite a bit of complexity, and we're going to go through those areas today. So because you are here attending, you will also be receiving an executive report. This is a great research report that we put together in 2019. It's attached with the presentation, and I encourage you to go through that. There's some great information, a great process for you as you're looking at these costs for your own organization. So you will get that today. Okay, so let's jump right in. We categorize outsourced services into 6 categories. It's administrative and HR, biomed repairs, service maintenance, clinical services, facilities and support services, finance, HIM, rev cycle, and then IT, telecommunications, and telehealth. And you'll see this presentation, there's going to be many subcategories, and of course the vendors will flow under that. But we categorize outsourced spend into these 6 buckets. And I want to share this with you. We took this from publicly available data for a Medicare cost report. This is something that we see consistent in all our work, that purchase services spend is increasing. In this particular healthcare example, you're able to see in their P&L, they pulled out the purchase services expenses from December 31st, 2017, and then, of course, in 2018, you will see that with the hospital purchase services cost in 2017, it was $185 million, and then in 2018, $221 million. I won't go through every line item, but I will tell you that I know hospitals are actively engaged in looking and reducing their purchase services or outsourced services cost, but this is still an area where we see the costs are increasing. That could be for a number of reasons, but this particular health system's view is a typical journey that we see most hospitals. And why do hospitals or why do you folks on this call outsource services? And there are four main reasons why hospitals will utilize services from an outsourced provider. They don't have resources or can't access some of the skills. It's more cost effective. It requires a significant capital or technology investment. And one we see quite often is there's some innovation and best practices that some of these organizations have that you want to tap into, and it's either used as a temporary support or a permanent solution. And why outsource agreements have to be managed and monitored. And we're going to talk about some opportunities and cost savings, but we've been talking to many of our hospitals about the need to manage and monitor them on an ongoing basis, but there's some real inherent issues why there's a challenge. There's no automation to gain the line item visibility. Those line item details are on your invoices. Every aspect is manual to look at that outsourced agreement, making it difficult to validate utilization. And the agreements are so complex, as we'll show you today. They have so many moving parts, and with everybody having to do more, the resources to really kind of get your arms around some of these agreements, it doesn't tend to get that management and monitoring attention that it could. And then there's always new services that are being added to the agreement, and it's also best practices to be able to compare within hospitals the performance of those agreements. So the purchase services cost savings analysis, I'm going to kind of go through these individually, and then we're going to talk about them as we show you some case examples. But there's significant spend in purchase services, right? It's probably about 50% of your non-labor spend. And your roadmap to cost savings will always begin on your contract and your invoices. The invoices are critical to not only being able to identify cost savings, but to control spend. We talk a lot about zero-based budgeting, but really looking at those line item details to see, are all these services needed? And being able to say, what are my top 200 service costs by line item, by department? And really getting an understanding of the drivers of cost, and then performing a pricing analysis. So how does everybody here benchmark? And benchmarking is great, and we perform a lot of the benchmarking, and we encourage our hospitals to have different sources to benchmark and also to set new pricing standards to go beyond benchmarking. Remember, benchmarking is the norm. It's the average. And so we always say, well, how can we think differently? How do we exceed the norms in the industry so that we could reduce those costs and then really be able to tightly manage them? And also tracking cost savings improvements or just basically also monitoring those line item costs. So we're going to talk about that today. So before we start, I have a first question for everyone. On your large outsourced service agreements, how confident are you that your hospital or your health system is paying the right price for the services and you're not overpaying? So how confident are you on your larger outsourced agreements? Are you 100% certain? Are you confident and you're receiving competitive, good pricing? Are you so confident you have a hunch that something maybe isn't right? And maybe there's opportunity in the agreement, or you're not confident. You just know you're overpaying, and you know there's opportunity. So if you wouldn't mind just answering that poll question, and we can continue. And while everyone's answering that, we're just going to wait about 10 seconds to get some answers. I will tell you that a lot of feedback we get is there seems to be a so-so confidence level because there are so many moving parts. And I'll tell this group here, and I believe it's in the slide coming up, but remember, services are performed and then invoiced, unlike supplies where you buy supplies and you have a record of that. So the first document or the first entry of record is on that invoice. So there's got to be this relationship to say, okay, I'm bringing in an outsourced service provider. They're going to bill me what they did on that invoice. So I think predominantly, and this is exactly what we see and we hear, is that so we have a hunch that something isn't right, and it's just the nature. So I appreciate everybody, providing their feedback, and it's what we see and what we hear, and really what happens in the marketplace. So I'm going to continue. So I appreciate your answering our poll question. So based on our experience, there's 4 mission-critical requirements to manage and monitor your outsource agreements. Number 1, you need to see the line item details to identify cost savings or manage, right? So you need to have access to line item details. Number 2, you have to have a thorough understanding of your clinical, financial, and operational terms, right? Not all agreements have clinical terms, but in many cases, these are large clinical outsource agreements. And number 4, it's got to make informed decisions and understand drivers. So this is understanding the benchmarking. This may be you want to do something a little different and have a risk share agreement. This could be having a brand new negotiation strategy, but that's important to be able to make those decisions based on a couple of different factors and understand the drivers of cost. And number 4, and this is the basis really of our webinar today, is how do you get out in front of those cost savings? It's really, once you're renewing the agreement, you've gotten new pricing and you feel good about this contract, how do you keep those cost savings and how do you get out in front of it? And that's a big part of our messaging, is how do you automate this process? So we're gonna tackle this first one. There's of course unprecedented pressure to find cost savings, and this is about the line item details, right? Finance, the department directors, supply chain leaders. There's so many people in the hospital that need to get access to the line item details, right? All those line item details, the utilization is all trapped on the invoices. This is an example. So I don't know how many everyone on the call, this isn't a poll question, so you don't have to answer it, but if I'm sure everyone on this call has seen one type of a purchase service invoice or another. This happens to be storage, and this particular case example, this system had numerous hospitals, thousands of pages of invoices, tens of thousands of line items, and buried in an invoice was a 2-cent line item fee. That was a pricing error. Annually, this hospital was overpaying by $624,000. So the opportunities, the overcharges, all your utilization are all buried here on the invoices, which is inherently the big challenge for outsource agreements. If you can imagine, a 2-cent line item fee would equal $624,000 in unnecessary costs. This is another example. This is regulated medical waste. I think some people might have kind of see these invoices again. There are hundreds of pages, thousands of line items. What's interesting about this is this invoice was paid. We went back and did a very comprehensive review of this outsource agreement for our client, and buried in that, if you can see that small little line item there, it's in yellow, but we bold it here, was they called it a monthly fee increase, and it was a $33,898.80 charge, and that was another error. That was paid, because how difficult is it for everyone to go and look into the details every month? It's virtually impossible. And managing and monitoring is the way we're not only going to be able to achieve cost savings, but really it's the way we're going to keep them. And I often say that this is the untold story about outsourced agreements. It's what disciplines are put into place on a monthly basis so you catch the 33,000. I mean, everybody knows, hospitals are really, striving and achieving great things and cost savings and, putting new practices into place. These kind of charges eat away at all those cost savings. And we want to help hospitals get ahead of that and be able to identify those. Rich?
Yeah, agency staffing is one of the biggest purchase service spend for hospitals and health systems. And as you can see in the back of this slide, this is a typical invoice, which has a lot of the information that's necessary to make decisions. And just getting that information and putting it on Excel moves it from the aggregate to be able to manage, and not only manage, but be strategic and proactive in making decisions.
So we're going to give you a little background. We were asked to perform, I think there was somebody's question too, will we cover staffing? And I think we have two staffing examples. We were asked by a New York Health System to help with their staffing renewal and to be able to benchmark and provide the historical data and perform an RFP. And you'll get these slides so you can kind of go through the details on this. But as an overview, it was pretty much a typical RFP. But why they asked us to help was because this was such a large spend, and they needed to get to, like Rich was talking about earlier, they needed to get to all these line item details. I think everyone is also familiar with the staffing agreements tend to either be on invoices like this or sometimes even, unfortunately, handwritten. So they needed to be able to get a 12-month historical spend to be able to understand every single bit of utilization, to be able to benchmark, and not benchmark 50%, not benchmark 70%, but benchmark 100% of what the hospital was utilizing. And so we did that. We did that work for this hospital, and really also uncovered some utilization trends and overtime rates. And in total, we saved them 16%, well over $800,000. So this is a kind of three-step process. We always create a baseline data, and as I said before, it's so important that as you're performing analysis that you get a 12-month history of the spend in any of your outsourced agreements. And you can't rely on the vendor to do that. I can't tell you how many times where the vendor has partial spend data, a lot of sometimes can't access all of them, and you have to get that data from your invoices because that's your true utilization. That's the true record of what those outsourced services cost you. So you've got to pull that 12 months out. You can't spot check. You can't do the last 3 months. You have to have a comprehensive view of what the real utilization was in your hospital. And of course, putting together an RFP that's very dynamic, that that doesn't have to be a 100-page RFP. It just has to be well constructed and really not only have pricing aspects to it, but to this client, they had some clinical and operational needs that were very important to them. And of course, we're a big believer in these presentations, whether they're on-site or done via WebEx, but understanding, being able to have a Q&A session and having a scorecard and being able to check references, and just putting together this whole process is very important. This is not unlike any other large outsourced agreement where because the services they're performing could have many aspects and many implications to the hospital, the due diligence, either as you start a new relationship or frankly even as you're in one, maybe you're renewing an agreement and maybe you want to take a step back and you want to reassess and really go through some of this process again, which sometimes makes sense. We have a lot of hospitals who really will put out an RFP or want to renegotiate, but what they're looking to do is sometimes it's about pricing, but sometimes it's about the services and really being able to reset and have some different expectations.
Right, and the RFP really, without the line utilization, the details, there's opportunities that are missed. And, back to just, if you could see the utilization in the back end, by department, by specialty, by RN level, and then not only regular hours, but overtime on call and callback. And really what comes on with the utilization and understanding is that you also see where the variances are within just the same type of nurse, right? So, the questions are, why is a med-surg nurse, in one department, in one hospital being charged or has an hourly rate of $65, in another department, in another hospital, it's at $75. So this just gives you the idea of understanding all of the line items, all of the nurses, all of the different specialties, and putting it all in one and making it powerful. And then we see, just as far as the results, now again, this is an example of a 3-hospital health system, and they're different departments and the total spend, and then broken down by what the impact was from this RFP.
And so this kind of work really gives a different view on whether it's opportunities, cost savings, or really what those drivers of spend, as I said earlier, and really understanding what those drivers are important, because you're able to make some different decisions as you move forward. You may, depending on where the largest spend areas are, you might want to make different decisions. You might want to focus on a hiring campaign, or whatever the outsourced provider is offering to the hospital. Remember, it's not all or nothing. There's many hybrid models where if you've got an unusually high spend area and you're using an outsourced provider, remember, you could make some decisions to insource some of that. And there's an outsourcing example we'll give shortly. But remember, you always want to think innovatively and think differently. There's always different options in how you approach working with outsourced providers.
And then just getting all that information together, sorry, Lisa, just as far as the overall, now you pull in the benchmarks. So understanding, the variances within the health system as far as pricing and within rates. But now this is the time, once you have all that data collected and put into one source, now that's when you benchmark.
Right. And that's, we speak often to our hospitals, and when we do speaking events, is that a lot of times people go right to benchmarking. Well, let's benchmark. And we say, wait a minute, benchmarking's got to be the third step in a process. One is you have to understand the historical spend. And 2 is to understand any kind of variations, trends, or things that may be an anomaly, or just you may want to think differently about. And number 3, you go to then benchmarking, and benchmarking with a complete view of total spend. So number 2 in this area is, we spoke about there's 4 critical or mission critical components. Number 2 is that these agreements are complex and there's many variables. And so understanding the clinical and financial and operational terms are so important. Sometimes some of the frontline users don't have the agreement, so it makes it difficult for them to be able to understand the terms. So many times when we're working with hospitals, and we're working, whether it's lab or radiology or biomed, and we're talking through the agreements and showing maybe some, it's a tiered agreement, or there's an agreement that has a credit, and we hear, I don't have access to the agreement, or I don't have access to the amendment. I would have looked out for that, for that credit. So it's really important that those frontline users understand those terms. A lot of these agreements are bundled in different ways, and they have variability in their structure, and we'll show you some examples of that.
Right. This is one example for record storage, where there are multiple hospitals within the same health system had different rates and different contracts. And just getting and standardizing to competitive pricing, just even within their own contracts, was a $25,000 reduction.
Now, we took that a step further, and we benchmark these individual rates. But this was important to understand for this organization that within their different hospitals, they had a variation in pricing, and in these instances, you could there's an argument to be made that you could even seek a credit because there shouldn't be those kind of variations. So, outsourced EVS agreement. So this is interesting because we were asked to perform for this hospital. It was a very, very large agreement, and of course they kind of had this hunch that they weren't getting the right pricing and they were being overcharged. But they also felt like they weren't getting value for their money, and they had some issues, with service, with cleaning in certain areas. So in this case, not only did we look at historical spend, and we looked at the drivers and they benchmarked, but we also conducted quite a bit of interviews with different people throughout the hospitals. And I'm a big believer in connecting the frontline users into into these discussions. And so sometimes the frontline users are the department directors or managers, but sometimes they're just people who are they're employees, and they're also users, and they can give you some of the best insights about what's really going on. So in this case, as an overview, we looked at their costs, whether comparing and benchmarking overhead costs, looking at the individual costs. This is a great example of the variations, right? So they were being charged licensing fee, software fee. They had startup costs, which were actually billed in error. They had general liability insurance, payroll processing, and so all these costs were embedded into this EVS agreement. And so we actually benchmarked every single cost and looked at best-in-class pricing. And even though we didn't end up, the hospital didn't want to change anything in terms of the employees, they did ask us to benchmark, okay, where are we in terms of staffing? And they wanted us just to have an understanding of where they were comparative to the marketplace. So as you could see, they had 66 employees, 5 managers, and that's what we benchmarked to in terms of where they should be in the marketplace.
This is a very common pain point for many organizations is the nitric oxide. It's under clinical purchase services. This vendor had a patent on its device that essentially eliminated its competitors. They would come in on one-year contracts, give 3 options: platinum, bronze, net hourly rate. And most organizations would take the platinum plan with unlimited usage for a fixed fee, and then they would be refreshed each year. So this is an example we pulled out of a client with the start date time, end date time, and it's really interesting. And some of you might want to go back and perform this. This shows the total hours the machines are turned on. Again, invoice sample. So buried in here is an example of an issue that, just looking at it, you wouldn't see it, but obviously we highlight it, make it easier here, where the meter is actually left on. Now, it's interesting to note that the meter is left on, but the gas is not being used. So it's just the mechanism on top of the unit that's being left on. And as you can see, the highlighted area here, that on July, the one that has 107 hours. So it's July 1st, 2018, and then it gets basically turned off on July 6th, 2018 at 6:30:22. And if you look at the line below, it's the same lot number, serial number. It's turned on 17 seconds or 15 seconds later. So this is a real example of when that machine had been left on, someone went to use it again, and then like, oh, wow, it's on. And they turned it off and turned it back on again. But, what happens is that, even if you're under the platinum plan, which it's unlimited, what happens is when you do this and the next year they're doing a renewal, they're adding in that 107 hours. Or maybe it should only be 4 hours. So we did this for one of our clients, and when we went back and did the analysis on the net hourly rate on these issues that had occurred, the baseline got adjusted and the organization saved almost $225,000.
So I want to talk a little bit more about this. So this is a clinical purchase service area. This is actually a chargeable item, and it's an amazing service. So this service saves lives, and it's very, very important. And sometimes, everyone's like, oh, you got to be careful. And like Rich said, they had a patent, but there's a newer player in the market now. And what we say is, we want our hospitals to pay the best pricing, right? Why should one hospital pay more than the other? But what's also so important here is that, as you could see, all the details are in the invoice, right? So no one's reporting out to the hospital, listen, you had on July 1 or July 6, you had 107 hours of usage, even though the gases weren't being used, the tank was on. That's not reported out, but it is put on the bill. So, that's just a perfect example of, of why going to the invoices and when you're doing any kind of initiative, why going to the invoices is so important, because you're going to see so many drivers of cost, utilization. You're going to pinpoint things I didn't know that was going on. I didn't know that's how they billed us. All these things are going to come to light. So this is the outsourcing to insourcing analysis. We had a client who outsourced their SBD management and some employees, and they had done so for many years. And so we were asked it was interesting, we were asked to help with the renewal with the incumbent, and we did the analysis, we benchmarked, and then during the process, we mentioned that would they ever consider maybe insourcing, because the costs were just so dramatic. There was such a difference, and the area where this hospital was located, they could find the skill sets needed. It would require some training and some additional costs, but when we spoke to the CFO, she had asked us to kind of do some analysis, walk them through, I don't have it here, but what it would take to get them to bring that outsourcing to insourcing their SPD. And what we found was it wasn't necessarily a heavy lift. And in fact, it got great support in the OR. It was great support throughout the hospital. And so this was just a tremendous, cost savings, but it turned out to be a big quality win. It turned out to be a big win for the organization because, those costs were escalating every year. But there was support to bring that in-house. So the reason, for this is that just because your organization has always done something a certain way does not mean you always have to do it that way. And listen, they could have said, let's just stick with what we're doing now. We just want to save money and make sure we're paying the best price. But sometimes it's good to be open to understand that, because maybe you won't do it today. Maybe you'll make that decision in a year or two. We've got a couple of hospitals that know that there's a significant opportunity to bring the services back in, and they want that analysis, and then they plan for it 2 and 3 years down. And I think that's a real smart way to look at your outsourced agreements. Are there any that you could bring in-house? And it doesn't mean you have to do it today. You could do it a few years from now. So that third requirement for management monitoring is really making these informed decisions and understand the cost drivers, right? I think everyone on this call probably has had an experience negotiating with their vendors or their account representative, and it's not getting easier. In fact, we're seeing that there's a big escalation in the vendors being trained in negotiations. And really, you hear a lot of moving away from, I don't want to talk about line item cost. We want to talk about value. I want to give you the holistic view when we price out. I don't want to show you every single line item, and I don't want to explain to you where all the costs are. And we say you absolutely have to do that. We want to understand each driver by line item. And I think that this is the next slide. So this is one example, and we've got tons of examples, but this company called Pricing Insight, all they do is that they train companies like Staples or Stryker. They go into their their spend or their SKUs or what they offer, and they create a new pricing strategy. And it's interesting. They'll actually say they reprice 7,000 agreements, or they reprice 5,000, and they increase their margin by 7% or 8.5%, and added $7 million. And you've got hospitals that are getting lower reimbursements, and now they have the vendors that are creating pricing strategies and complex agreements, and it's a very challenging environment for hospitals because the majority of everybody that's working in a hospital is working for patient care, and of course you have the business side, but those resources are there's so much that has to get done, and now you have to tackle pricing insight and reprice, and we see so many times where we'll track the company's list price and they get changed every year, and so the discounting doesn't even matter because the list price has been changed over and over so many times it becomes irrelevant, and so that we have to tackle those negotiations and those benchmarkings very differently. So here's a second poll question. How do you feel about conducting pricing and contract negotiations with your vendors, right? So do you love it? You'll do it, but you'd rather let someone else lead, or you like to avoid them? And, we got somebody who loves them. 3 of them. I have to. 4. I've got to meet you. 5. We love them too. So it's funny because we get a mix, right? We do, of course, in this business. You've got a lot of people that really do enjoy negotiations. We're a big believer in talking about being disciplined in your approach because they have such discipline. But most hospitals are telling us that they don't mind being part of the team, but they definitely don't like to lead. And we've got a couple of people who really just they don't really enjoy it at all, and because of the relationships and the dynamics. So thank you, everyone, for sharing. I appreciate that. So this is a pricing strategy that we see is minimums. And we never, ever will put into a renewal or never put into a contract a monthly minimum. But we do see those in agreements that hospitals have engaged us to kind of review. And I think one of the questions that someone asked, and then I will address it later, but I think they asked, how do you balance vendor needs for revenue guarantees with health side systems needs to upsize and downsize? And I think this addresses this right here because, I guess in this case, initially, this vendor needed to have revenue guarantees, right? So this addresses that question. However, when we started to really ask how long this vendor was, performing their services, it had been like 12 years. So a lot of that capital, they had not changed out capital. A lot of those guarantees weren't necessary. So, so instead of just focusing on benchmarking that rate, we also had unfortunately, we would have liked to have taken out that monthly minimum altogether. But it was a challenge for a number of reasons. But we got that to be reduced, right? Reduced from 19 to 16, and of course getting that cost per case down. It turned out to be $147,000 savings. That's big savings. But this is a pricing strategy. So not only looking at that monthly minimum, but also looking at reducing the monthly minimum. Really, our first line is to get rid of it entirely. You should be paying for what you're using. But we understand, like this, one of the attendees had asked, how do you balance the need for revenue guarantees? And I think the way you do that is you have to understand, are they investing capital? Are they investing technology? Is there some reason that they need a revenue guarantee? Because if they don't need a revenue guarantee, then there's no reason to give them a revenue guarantee, right? Their revenue guarantee is providing services upon you needing them. It's real utilization.
And when we deal with clinical purchase services and making informed decisions, it's always critical to go back and get reimbursement information. So this example here is we were negotiating a lithotripsy agreement, and this is analysis done over a 3-month period, about 37 outpatient procedures. And what we came back and it was really powerful because at the end of the day, the hospital was only making about $140 per case based on the payer mix of the patients.
This is a telehealth services. We're seeing in the last few years that telehealth outsourced agreements are on the rise. It's not just for stroke telehealth. It's growing to tele-ICU and to a number of different areas outside of traditional areas. And so in this case, it was there was two options around the benchmarking. Of course, they had a startup fee, a monthly fee, how many encounters, and this current client had an unlimited 24/7 plan, and it was based on a per diem rate at the facility. And so when we reviewed their rates, of course, we changed their structure to we had two different structures that they could go to, but we ended up saving them $147,429 by having a per encounter rate, and depending on some of the services that they were needed. So the fourth area is the sooner the hospitals can get out in front, the better. So this is really about enabling the staff and enabling different parts of the team to be able to manage the spend and giving them the opportunities to automate and access line item details. So this is an example. Reference lab is a pain point for most hospitals. In this case, one invoice had 5,719 tests, and hospitals they get hundreds of pages of invoices for many different reference labs, and typically there's a lot of pricing issues. And so whether there's pricing issues that they're not getting the right price, what we find a lot of times it's off contract. It's new tests that are being used that don't have an agreement attached. So in this case, out of $500,000, there was close to $200,000 that didn't have pricing attached. And in addition, we were really able to help this client not only benchmark, but also look at opportunities to bring tests in-house, because they were able to see the test by line item detail in a way that they could sort, and they could have some trending analysis as well. And this is a different client, different view, where we're trending, like I said, tests utilized in the most recent 3 months, and 19 tests that were recently used. Again, giving hospitals a line item data to say, wait a minute, I didn't realize that we were using these 19 tests. These are recently used. We thought we had a low volume, and I didn't realize the amount of volume. And then they can make different decisions. First, they have to get this. They got to benchmark and get it on contract. But do they start making different decisions? But it's always interesting to see recent utilization. And the only way you're able to get this insight is if you're managing monitoring on a monthly basis. This is another view. This is the off-contract test insight. And these are the top 15 contracts off contract, and you could kind of see that trend. This is an interesting example. We're going to have another one for regular medical waste. This was their off-site location. We were able to benchmark their minimum fees from $105 to $35. But what was most interesting is actually looking at by location their spend, but specifically their contract allowed them 429,000 pounds. But to look at the real utilization, they were only utilizing 350,000 for the last 5 months of average. In essence, they were overpaying $9,700 per month. That's $121,000 just because that their contracted weight had exceeded, or their contract weight was way more than what they were actually using. And again, because we had this, we were managing and monitoring. We were able to pinpoint this, and then there's nothing wrong with renegotiating a contract in term. A lot of people feel like, oh well, I have my chart, and my chart says these are the contracts that are coming due. I'm going to renegotiate them. 9 months out, and that's great. You need to have the view, and you need to be doing that in a timely way. But if you're managing and monitoring all your outsourced agreements and something like this happens, there's no reason why you can't say, hey, wait, time out. I got to bring this vendor in. We're not matched to our utilization appropriately. I can't have the hospital spend $121,000 to pick up air. We need to right-size this. And I think those are conversations you could only have if you're having this ability to measure and monitor. So this is a little bit about our approach. We've been kind of talking about it throughout the webinar. We've got about 7 minutes or 8 minutes before we do Q&A, so I'm going to kind of go through these slides quickly. I want to get to a couple more examples. I think examples tell the story in a very unique way because it's real life. But we're a big believer in getting the line item details. We have an automated patent process to get the invoice line item details and then reconcile it in real time. And we're helping our hospitals to give them the tools and the insights so they understand their contracts. And this is my approach, but it could be your approach too. We're utilizing market intelligence, and we're understanding different dynamics and preparing, making informed decisions in a way that you can negotiate the best deal, the best pricing. And then you're putting in some kind of automation that you're using real-time data and performing it, and it has to be a monthly activity in order to get out in front of these cost savings. It doesn't become a one-time event every 3 years. You wouldn't manage your supplies that way. We've got to get everyone kind of managing their services spend, the outsourced services spend in a different way like you manage your supplies. So these are the 4 critical components, right? These are mission-critical requirements that you see the line item details to identify cost savings, you understand the clinical financial terms, and everyone that's touching that agreement must. You're making informed decisions, and you're getting out in front of those cost savings. So we have a few other case examples, and then I would say in about 5 minutes we'll open it up to some questions.
And these 2 examples are from VIA client examples from Red Cycle, and they clearly show the importance of analyzing and comparing the current vendor invoices for a comprehensive benchmark analysis. And really, just if you're benchmarking from contract alone, you're missing significant cost reduction opportunities. So this is the denial management. And really what it was, we took a look at the existing contract. There was 3 parts to it. There was placement above $1,000 and less than 90 days of discharge had one rate, greater than 1,000, greater than 90 days of discharge, and then any placement values lower than 1,000. And when you look at those placements above 1,000, they were pretty competitive. But when we went back to line item details, again, not benchmarking from the contract alone, resulted in a $227,000 cost reduction. And what was happening was the system, the HR system, was sending the denial report to the vendor with a zeroed amount, and therefore the rate was defaulting to the highest percentage. So they weren't getting any of the rates on the placements over 1,000.
And so this
obviously
is
there was some credit. Yeah.
Right. Sorry. So, this is an example of not benchmarking. You wouldn't have found this. This is beyond benchmarking. If you benchmark, this is about really engaging the frontline users, really understanding your agreements. I mean, these outsourced agreements, they are complex, and in this example, they tie into their system, and you have to understand, are the systems set up correctly, right? Same thing happens with lab. If you have an interface, we found that sometimes the interfaces don't work correctly, and really this has to be a comprehensive review of agreements, processes, pricing. You have to put it all together. It can't be done, quickly because opportunities like this, a $227,000 opportunity, would have been missed, and then a $56,000 credit.
Right, and this is another example similar where the system was not set up correctly. When we initially looked at the contract, we were waiting on the invoice statements for the extended business officer early out debt collection. We saw an opportunity. It was between $80,000 and $115,000. But when we started to pull in the 12 months worth of invoices and statements, we identified that the new rate that they had negotiated when they went live with their new HR system had not been put in place. So they were still paying the previously high rate for collections. So not only did they reduce costs by over $213,000, but they also received credits back, almost $57,000 in credits. And this is another example just in the rev cycle side, where the patient eligibility verification, which is a very common financial tool being utilized within revenue cycle. When we did the analysis for one of our clients, they had put in it was a contract that was just coming up on its the end of its second year of a 3-year term. And when we pulled in the utilization on the transactions, we realized that they were trending higher. In the last 2 months, they were going to go past what their allotment was, and therefore they were going to pay a penalty. So what we were able to do is not only negotiate a new contract, but also eliminate the penalty rates. And it was interesting. They had one health system that had recently been entered into their or acquired, and the vendor had put their transactions into this main contract, even though they had a separate contract. So just going to the details and understanding where those transactions were pointed, that was it was a lot of the 68,000 that we were able to eliminate because, they were actually paying for it in another application.
I'm probably going to end with this example, or maybe one other, and then we can go to some of the questions. So this was interesting because we were working with a health system and reviewing all of their current technology agreements. So we were asked to kind of go A to Z, look at everything in term, and identify pricing, utilization, any kind of cost savings. So this hadn't come to us because this was a brand new purchase, and at the last minute, someone said, "Oh, you should send this to Vi to look at because has technology components." And so while it gone through an RFP, they actually utilized a company to help them with the RFP. When we got this agreement to review, all of their professional services were all list price. No one had negotiated negotiated professional services. And then secondly, which is also a big miss, was their maintenance costs. So they were implementing at one hospital, yet at all hospitals they would be paying maintenance upon signing the contract. So I think there's some savings numbers. So when we redid the negotiation, it was another $1 million in cost savings. And an example, they had an application specialist. They were charged at $225. That was the driver that was for the implementation of this, and we benchmarked at $139. We did get that benchmarking. And the system had saved numerous years, in professional service fees and also on the maintenance. And last question, and I think we'll try to do one more case example, and we'll open it up. So, have you, as an organization, benchmarked all of your professional services hourly rates across, the organization in the last year? So that's saying, okay, I have rates, whether that's in marketing, legal, IT. I mean, that's going all throughout the organization and saying any kind of hourly rate. Have you benchmarked them to make sure you're paying a competitive rate? Right. And the reason why I asked this question, and I appreciate everyone answering, this is typically what we see is that 90-10 or 87-12. It's what we see because there's a lot of this gets embedded in the invoices. And then the other point is that the vendors are pushing back so much on these professional services fees, but the reality is there's great data around benchmarking. They're using this to really push up their revenues by adding higher pricing for professional services. But if you want to kind of have a big win in your organization, I would have an initiative just to look at all your professional services fees, hourly rates, and get them benchmarked. That could be a big win. And remember, in-term, out-of-term those agreements, you can negotiate this at any time. It's a great area to look at. So I'm going to skip through. This is a really good one. I'm just going to mention this, and then we'll go to any questions. Sometimes agreements have different areas where they're attached to revenue. and I believe this is the one. Just give me. Oh, well, no, this isn't one, but this is one good to look at when you get the deck. We had a client that was charged triple for their 3 times, so a triple amount for their patient statements. They had thousands of invoices, and we were able to identify their patient statement accounts being billed 3 times. Of course, there's a cost savings and then a credit. And I'm going to jump to one last component, and then we can go to Q&A. So this is a marketing agreement, and part of this was the acquisition of new patients, and this company was paid a $21 appointment fee for every 2,500 visits. And so the long and short of it, we asked for some reimbursement information, we asked for charge information, and as it turned out, the marketing company was actually making more $21 an appointment than the hospital was, because it was such a large amount to be paid per new patient visit. And so this was a savings of $180,000. So I'm going to end it right here so we have time for Q&A. I do appreciate you attending the webinar. It's not over. Please, we have some questions that were sent to us earlier, and then if you have some questions now, please ask. If you want to schedule a call with myself or Rich, I believe the information is as part of this webinar. We'd love to be able to meet you and talk with you about anything that you have, any questions you have or need. So thank you, everyone. Drew, I think I'm going to give it back to you for Q&A.
Yep. Thank you, Lisa and Richard, for your presentation. We'll now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining, and questions that are unable to be answered in our allotted time will be shared with the speakers for follow-up offline. So first question, Lisa and Richard, I have, is outsourcing biomedical services rising?
Yeah, it's a great question. We are seeing that these costs are rising, and we're seeing it for a couple of reasons. One is some of the price points are increasing a little bit on the service like professional service costs we saw earlier. We see that the components, the pricing on those. But the big area on the rise is how these contracts are constructed, and so they're adding so many variables, and they have hidden fees and clauses where even if you enter into an agreement that's a flat fee agreement, there's clauses that talk about damage waivers, and so now hospitals thought they were going to be saving so much money have actually increased their costs by outsourcing. So we do see a trend that outsourcing or the biomedical outsourcing has been increasing. It doesn't mean that you shouldn't outsource if there's anything wrong. What it means is that those costs should be benchmarked and analyzed, and utilization should be reviewed.
Great. Another question. Are there any get-out-of-jail-free clauses you recommend being included in an outstanding agreement?
Right. Yeah, that's a great question too, because if all else fails, I want to push the button, and get that parachute out of the agreement. I think the best clause is really having a 30 or 60-day termination without cause. Right. So if you've got that in your agreements, which I would absolutely recommend, is to have a termination without cause. I know sometimes that's challenging, but that would be your get-out-of-jail-free card.
Great. I think we have time for one last question here, and that is, how do you balance vendor needs for revenue guarantees with the health system's needs to upsize or downsize?
Right. And I addressed that question a little bit during the presentation with that slide that talked about having those monthly minimums, right? So that vendor needed to have a guarantee, i.e. that monthly minimum. So I think that the best way to balance a vendor's needs for revenue guarantees versus a health system being able to have flexibility and to downsize or to upsize is to understand their drivers. If they're offering a service and that service isn't tied to a large investment or whatever that may be, I don't feel like you need to give a revenue guarantee, right? I think the revenue guarantees for a vendor are only put in place if there's some huge driver cost. But sometimes even those investments, that's just part of what an outsourced provider does. They are making investments. They're making investments in your organization. So by doing such, they may have to have, invest in maybe they're upside down for a little bit. But, that's part of providing outsourced services to hospitals. And I think at the end of the day, the need to guarantee revenue on the vendor side is probably a lesser need, but the greater need is to understand, are you utilizing the right services? Are you paying the right price? Is this the right vendor for your organization?
Great. Thank you. That concludes the time we have available for questions. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. Thank you to our audience for joining us, and thank you, Lisa Miller and Richard Dormer, for your presentation. And thank you to our sponsor, Vi Healthcare. Thanks again for joining. This concludes today's program. Have a wonderful afternoon.